Hi everyone, my name is Dr. Lasker or Imran Lasker. I'm just going to share my screen quickly so that we can hopefully look at a few cases. Some of you may have come to previous talks, and we've been going through a few plain films and kind of just sort of getting to grips with plain films. If you haven't seen those, it may be worth going back and watching some of them because we kind of went through a few plain films and then we started introducing a bit of CT. And this today is going to be a little bit more, I guess, yeah, CT heavy, I think. But we'll have a few plain films to help us go along. So hopefully you will have the link. I think Seidel has just put the link on there for us, and you can see my screen. So if you don't have the link, don't worry. We've got this. You can watch it on my screen, then hopefully just work through the problems together. So one of the things that I was always taught is that there's no point in just knowing the answer, right? Because knowing the answer is just half the battle. You need to know how to get to the answer. So hopefully by watching the previous talks, watching this talk, I'll give you sort of a framework as to how I guess a radiologist looks at scans. And if you guys are radiologists, maybe it'll help you. And if you're just interested in radiology, and maybe some of the cases are something that you'd be up for looking at. Right. I'm just going to get this particular scan. So this is case number one. Unfortunately, just opened up in what do you call it, lung windows. Let's just go with abdominal pain to begin with. And I'm going to click on the scroll button. And also, if you are finding that things are going a little bit slow, click on that little cloud button and that just sort of downloads it. And you can see that red button going right across. It shouldn't take long. Obviously, it depends on your internet speeds. And mine might be a bit slower because the kids might be watching Netflix. They're really getting into the Hobbit of all things. Okay, so we are going to be looking at this patient. They have got abdominal pain. And for those of you that are being able to get through the scans quicker than me, then you just go ahead and write whatever you think is going on this study. And I'm going to work through it slowly, so that I understand that not everyone is coming here with the same ability. Some people are ST1, some people are even thinking about doing radiology in the first place and just very interested in looking at scans. So, which is a great place to be, by the way. Right, let's start from the top. We just have to kind of scroll through down a bit. And then one of the first things I always ask myself, because you're not always aware, is what phase of imaging is this, right? And if you look at the aorta, which is sitting over here, I'm just going to get the pen. There's a pen function over here, which is quite cool. So you see that thing over there? That's going to be the aorta. And that doesn't look as bright as the bone on this particular window. So therefore, this is not going to be an arterial phase image, right? And as you come further down, coming further down, you can see that the portal vein, which is sitting right over here, right over there, is slightly brighter actually than the aorta. So when it's slightly brighter than the aorta, then you must be thinking along the lines of this being a portovenous phase image, right? So what I normally do is this is what I'd highly recommend anyone to do if you're interested in imaging and reporting. Go right from the very top, go all the way to the bottom. Just look, just do one cursory look all the way down, all the way down, all the way down, all the way down, right to the very bottom. And if nothing popped up at you, then that's fine. Now you've got to do the legwork and see what's going on. So we do have the chest images on this one, and I'm going to just change the window. Hang on, let's move that out of the way to the lung windows. And they've got abdominal pain. So one of the things may be, have they got air under the hemidiaphragms, or they may have pneumomediastinum or something like that. But as you kind of scroll through, there's nothing like that. If you look at the mediastinum, which is this area over here, that actually looks okay. It doesn't look like there's anything going on there at all. Everything looks normal. And as you scroll further down, you may start to notice that when you look at the bronchioles or the bronchi around here, they look a bit thickened, don't they? I'm going to just zoom in and just show you what I mean. So zooming in, you can see that these look a little bit thickened and a little bit irregular. Okay, so that's something to think about. And as you kind of scroll through, there's all this kind of gunkiness sitting over here as well. And again, the bronchus and the bronchioles, as they go down, they seem a bit bigger than they really should be and very, very thickened. So you're looking at something that looks along the lines of maybe some traction bronchiectasis. So you've got these tubes, and then some of the lung parenchyma, because it's kind of fibrosing and pulling away, is pulling some of that tubing, and you end up getting sort of zigzaggy appearance. And on top of that, it looks like they've got a superadded infection. So there's lots of gunk sitting within the airways as well. So, I mean, that's a few things that we're already spotting here. So if we didn't find anything else and the patients come in with infection and all that kind of thing, then that could be a possible source of infection, couldn't it? But as you come further down, you start to see that you start to notice that the liver is there. And some of you have got very astute eyes that they may be able to see a little bit more than others. You may see there's a little bit of a kind of an enhancement difference between here and here. Straight away, there's a bit of a almost segmental enhancement difference. And what I'll do, I'll just do a bit of manual windowing And you might feel that maybe in this area here, looks a little bit brighter for some reason, or that looks a bit darker, maybe a little bit brighter here. So for whatever reason, you've got, looks like some areas have got a little bit more fat infiltration than others. So something to think about. Okay, so you may have a little bit of fat on this liver, a bit subtle, I know, but it's definitely got a bit of an enhancement difference. But as you come further down, you've got to start thinking about what can cause abdominal pain. So one thing that can cause abdominal pain is going to be cholecystitis, so the gallbladder. How does the gallbladder look? So please feel free to tell me what you think. But as we kind of scroll through, you start to notice that gallbladder looks a little bit thick-walled. We zoom in a bit. And then as you look at the fat around that gallbladder, you can see there's a little bit of fat stranding there and there. So look at the fat over here, very, very black, very, very dark. Over here looks very, very cloudy, very, very hazy. So that's not normal. It shouldn't look like that at all. And so therefore, this must mean that there's inflammation. So fat stranding results is because of inflammation. Now, you can't always see stones on a CT scan because you don't always get radiopaque calculi. You have to remember that a lot of the time calculi are going to be very cholesterol rich. And so you may have something that's isodense to the fluid, hypodense to the fluid, almost isodense to the fat, or you just may not see anything at all, but there still could be calculi that is causing some kind of obstruction. Sometimes you feel a little bit of irregularity going on within the liver, within the gallbladder. But on this one, I mean, maybe possibly there's some lower density within it, but you can't be 100% sure. But you've got the gallbladder sitting there. And then you've got to look at the intrahepatic duct. So you've got the portal veins, all these kind of hepatic veins, portal veins sitting here. And next to those, what you'll have are the intrahepatic ducts. And they'll be sitting like in this region here and this region here. But on this sequence, on this image, we don't really see much in the way of any low density adjacent to it, which must mean that there's no intrahepatic duct dilatation. If you had low density on one side of that vessel, then you're looking at intrahepatic duct dilatation. If you've got low density on both sides of the vessel, then you have to be looking at something like periportal vein edema, periportal edema. But in this situation, we don't have anything that looks like sort of intrahepatic duct dilatation, nothing convincing anyway, or not anything that we'd be particularly concerned about. But now, as you come further down, as we come back to this gallbladder, which clearly doesn't look quite normal, you can see that there is some fat stranding located there. And as you scroll further down, you've got the kind of the body of the gallbladder, and it kind of goes down to the tail. And as you come down to the tail, you've got these two hyperdense areas located within the sort of the neck, almost going into what is a CBD. And further down, actually, I mean, the CBD and everything else looks okay, but there's definitely what looks like a few calculi sitting there. So when you've got calculi sitting there on a background of what looks like an inflamed gallbladder, it's only really going to be one thing. It's going to be cholecystitis, right? But because we can't really stop there, we do have to look at everything else to be 100% sure there's nothing else going on. So we look at the pancreas, and the pancreas is sitting there, and that looks very, very normal. That looks like a nice feathery thing going a lot across the front. Look at the kidneys as well. Make sure there's no evidence of any hydronephrosis or hydroureter, and they look okay as well. There's no evidence of hydronephrosis or hydroureter. Both kidneys look normal. We can't stop there. We also have to look at the bowel, because that's the thing, like people don't turn up like textbooks, and part of being a radiologist is that you're still looking for other things once you've spotted the first thing. What I often say is it's the second fracture that gets missed. Most of the time, it's not the first fracture that gets missed, it's the second fracture, i.e. what I'm talking about is satisfaction search. We do have to keep looking. So if you keep your eye on the bowel over there, and we start scrolling upwards, just going through, making sure that the bowel kind of goes through, it's going through like this, kind of got this S sign for sigmoid colon, kind of going forwards. I feel like it's kind of going across the front, maybe. Yeah, going across the front like so, going across there. And then we need to find the descending colon, which is over here. Keep your eye where my mouse is, and we're still scrolling. Everything looks okay. So I'm going to just keep that there. Keep your eyes on the hit here just to make sure everything looks okay. Okay, everything looks okay now. Coming up to splenic flexure, that looks okay. Going across the transverse colon, that will go right across the front. So just have a look, going right across the front. Yeah, perfect. Now we'll get to this area over here. This all looks all right as well. Doesn't look like there's much going on with regards to the bowel. And then you kind of have an overall look at the small bowel, and there doesn't look like there's very much going on there at all. So have we finished? I mean, we could say that we're done now. I mean, it's kind of started. What else do we really need to do? But actually, as you kind of scroll through from the very top, you might have spotted that there's this little region that is sitting over here. Can you see that? It's almost like a little crescent shape like this, yeah? And it's sitting just outside the liver, and it's almost pushing it in, right? It's causing a bit of scalloping of the liver. And that's not normal. And then you've got to try and look at that and see whether it actually continues with the gallbladder. I mean, maybe it could be the gallbladder that's sort of just continuing its way forward. as possible. So what we've got to do is make sure that it doesn't, we've got to try and make sure that it doesn't connect or does connect. There's a very, very important distinction to make. So if you keep your eyes there, and what we might see is that either it's going to close off and then you're going to get gallbladder, or this is going to just continue to be the gallbladder. So as we keep our eyes there, keep watching. You know what, I might just zoom in just to kind of keep ourselves less distracted from everything else that's going on this image. Go back to scrolling, scroll through. So there we go. So from the top, down, 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 down. And then it kind of looks like it finishes, doesn't it? And then you can see gallbladder wall sitting over here, can't you? And then that looks kind of almost separate. And then there's maybe what looks like a little tract there, possibly coming this way. There does look like there could be some sort of defect located within the gallbladder wall. Very, very subtle, but there does seem like there's a bit of irregularity of the gallbladder wall there, and what looks like some sort of collection or some sort of fluidy thing coming forwards, superiorly and anterior to the liver, and to be more specific, we're probably looking at segment 4B of the liver. So that kind of opens up a little bit more. Okay, there's more going on than we initially anticipated. So now we're not just looking at a cholecystitis picture, we're looking at a complication of cholecystitis. What we're looking at is a perforation and a subsequent collection as a result of the cholecystitis. So I thought that'd be a really good case, because I think a lot of the time people will they'll see, they may just like look at this one bit and be like, yeah, cholecystitis, move on. But actually, this kind of patient may not get better, or may take a while to get better, because they've got a perforation and they've got what looks like a collection. And now when you scroll through, you can see, look, gallbladder, maybe with a tract there going that way, and then almost continuing into that kind of collection. And it's very unlikely that that's going to be a bit of like thin-walled gallbladder and thick-walled gallbladder. This is almost definitely going to be a collection as a result of a perforation of the gallbladder. And so what may need to happen is that they may need to go under ultrasound and try and drain this thing. So you can see how the management can change quite significantly, depending on what you're seeing. And so it's really important to sort of ask the next question and the next question, and the next question, not just be satisfied with just saying, oh, well, it's cholecystitis. What else do you really need to know? Right. So let's go on. So any questions at all whatsoever? I mean, do feel free to ask questions. The more interaction, better, really. Otherwise, it's me talking to myself, which I'm happy to do for those of you guys that listen to my podcast. I talk to myself all the time. All right.